afferents from the dorsal column system, that is, and after that they enter the spinal cord via the dorsal root, and the motor neurons of the anterior horn cells exit from the ventral areas of the spinal cord, and they form the ventral root, which then joins the autonomic fibers to form the mixed peripheral nerves. The dorsal root, which takes the efferent fibers to the spinal cord, the ventral root, which carries the efferent fibers to the lip, and autonomic fibers, that is the rami communicantis, which is shown over here. Yes, this all together joins to form a mixed spinal nerve. The mixed spinal nerve divides into anterior primary ramus and posterior primary rami. The anterior primary rami go on to continue to supply the anterior part of the body. And the posterior primary rami supply the axial and the back and spine. There are 31 pairs of spinal nerves, 8 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 1 coccygeal. The anterior primary rami supply mainly the limbs, non-axial skeletal muscles, skin of the lateral and anterior trunk and neck. The posterior primary rami supply the skin on the dorsal aspect of the body and sends motor fibers to the longitudinal muscles of the axial skeleton. Now, for clinical differentiation of lesions of root versus lesions of peripheral nerve or lesion of plexus, we have to understand the concept of myotome versus dermatome. A myotome is a group of muscles supplied by a single anterior spinal root. A dermatome is a cutaneous area supplied by a single posterior spinal root. The differentiation of root lesions depends on the segmental character of the sensory and motor signs and symptoms. The myotomes of the upper limb are uh, movements which have the strongest association with each myotome. For the upper extremity, shoulder abduction strongly correlates with C5 nerve root. Elbow flexion and wrist extension strongly correlates with C6. Elbow extension strongly correlates with C7. Thumb extension and ulnar deviation of the thumb correlates with the C8 nerve root, and finger abduction correlates most strongly with the T1 nerve root. For the lower extremity, hip flexion has strongest associations for L2, knee extensions for L3, ankle dorsiflexion for L4, big toe extension for L5, ankle plantar flexion for S1, and knee flexion for S2. While this is the detailed innervation of each muscle via each nerve and via the roots, the underlying roots are the predominant root innervations, both for upper limb and lower limb. Moving on to sensory innervation. The segmental innervation of the upper limb is from the nerve roots C5 to T1. This is the normal sensory distribution, although it can vary from person to person and there can be significant anatomical variation. This is the segmental sensory innervation for lower limb, mainly from roots L1 to S5. The dermatomes can be confusing to understand, but if we understand that we have evolved from four-legged animals, it becomes much more easier to understand. The cervical, thoracic, lumbar, and the sacral dermatomes. These are the dermatomal regions most likely corresponding to a specific root after ruling out the overlapping regions. The lateral aspect of the arm strongly correlates to C5. Lateral aspect of the forearm and the hand correlates to C6. The middle strip and the middle finger most strongly correlates with C7. The lateral aspect of the hand and lateral aspect of the forearm correlates with C8, while the lateral aspect of the elbow and surrounding arm and forearm part correlates with T1. The strip of skin over the inguinal ligament correlates with L1, followed by L2, L3. The medial aspect of the calf for L4, and dorsum of the foot and the anterolateral part of the leg correlates to L5. Sole, uh, not including the great toe and the ball of the foot for S1. The popliteal fossa and the upper and lower parts of the thigh for S2. The circular area, perineal area around S3, and proper perineal areas correlates for S4 and S5. Moving on to clinical features favoring root involvement. Sensory symptoms, radicular pain or root pain. It is a characteristic lancinating, electric or burning quality. often occurring with irritative lesions of the root. This is abrupt, sharp, well localized, and refers to a specific dermatome or myotome. It is accentuated or precipitated by maneuvers that cause increased intraspinal pressure or stretching of the nerve root, that is, coughing, straining, sneezing, Valsalva maneuver, or spine movements. There can be paresthesias or dysesthesias. Dysesthesia would favor a diabetic radiculo neuropathy or a diabetic radiculoplexiopathy. Absence of sensory loss does not exclude the possibility of lesion affecting a single dorsal root because of the significant overlap with nerves from other roots. When multiple dorsal root lesions are present, the sensory loss is evident and area of analgesia is larger in the area of anesthesia to light touch. For motor signs, ventral root lesion cause weakness and atrophy in the myotomal distribution of the affected root with or without fasciculations in the affected muscles. And there may be hypo or areflexia occurring in the muscles subserved by the affected spinal root because of the interruption of afferent or efferent spinal root. Common causes of radiculopathy are structure that is herniated disc, vertebral trauma, bony impingement from spondylosis, mass lesions, epidural abscesses, metastasis, facet joint arthropathy, spinal tumors, cervical rib, ACM, and tethered cord syndrome. Infection and infiltration may also cause radiculopathy for spine, Lyme disease, CMV, HSV, VZV, and infectious chemical or metastatic erythroiditis. Carcinomatous or lymphomatous meningitis may also cause radiculopathy. And post-radiation, especially in the lumbar plexus and brachial plexus, post-radiation for pelvic tumors and post-radiation for breast cancer, there is plexopathy and radiculopathy. Autoimmune causes, GBS and CIDP cause polyradiculoneuropathy. Sarcoidosis may also cause radiculopathy, and RA causes radiculopathy due to tannus formation around the vertebral bodies and the exhibiting nerve roots. Nerve root infarction, spinal dural AV fistulas, and epidural hematomas may also cause radiculopathy. And diabetic polyradiculopathy is a very common cause of multiple nerve roots being involved with strong dysesthesias, history and examination. The most common disc prolapse in the cervical region is in the C6 C7 interspace, resulting in signs and symptoms of C7 root involvement. Infraforaminal or lateral disc herniation in cervical region most often manifests as radicular symptoms. Posterolateral herniation presents with motor symptoms and signs, and midline will present to us with a cervical myelopathy. Lumbosacral radiculopathy, the symptoms and signs may differ according to the type of disc herniation. Could be a medial disc herniation or could be a posterolateral disc herniation. In the lumbar region, the most common disc prolapse is at L4 or L5 S1 level, resulting in signs and symptoms of the L5 or S1 nerve roots, respectively. The interspace, but not only interspace level, but also the location of disc determines which roots are predominantly affected. The posterolateral disc herniation, which is shown as B, affects the nerve roots lower, which are a bit lower than destined to the which are a bit lower in the intervertebral space. For example, if there is a disc protrusion between the L4 and L5 disc, the L5 nerve root is more likely to be involved in a posterolateral disc herniation. For a very lateral protrusion, it may affect the same root, that is L4 in case of L4, L5, and a very medial lesion may affect the S1 root, that is two roots below the L4 root. The central lumbosacral disc herniations, which are less common, may affect roots on both sides, resulting in bilateral pain, autonomic paralysis of the bladder and bowel, saddle anesthesia, and bilateral lower extremity weakness, that is quad equina syndrome. Vesper's curse is nocturnal lumbosacral and leg pain and paresthesias due to lumbar spinal stenosis or decreased cardiopulmonary compliance, which often causes patients to wake up from the sleep. I'll move on to neurologic signs and symptoms with nerve root irritation or damage from disc disease at specific root levels. For C5 root, there is pain at the neck, shoulder, and the anterior arm. There is a numbness or hyposthesia in the lateral arm. There is weakness of mainly of the extension of the shoulder joint, that is a deltoid, external rotators of the arm, and forearm flexors. Reflex changes are loss of reflex at biceps and brachioradialis. For C6 nerve root, reflex changes stay the same. Pain almost stays this. Pain is the lateral arm and dorsal forearm. The sensory findings are at the lateral arm, lateral forearm, and first and second digits. There is weakness of forearm flexion, arm pronation, finger and wrist extension. For C7, There is reflex changes at triceps, weakness in arm extension, finger and wrist flexors, and there is sensory loss at the third and fourth digits. The C8 nerve root results in pain at medial forearm, hand, and fifth digit with motor findings in the form of weakness of intrinsic hand muscles and loss of finger flexure weakness. For L4 radiculopathy, there is low back pain, buttock pain, being referred to anterolateral thigh and the anterior leg. There is sensory loss over knee and medial leg, and there is a weakness of knee extension. The knee jerk may be decreased or lost. For L5 root, there might be low back pain, lateral thigh pain, and anterolateral calf pain with sensory loss over the similar regions, sensory loss over the large toe and dorsomedial foot, and there is weakness of thigh adduction, knee flexion, and dorsiflexion of the foot and toes. There will be no reflex changes. And for S1 root, there will be a loss of Achilles tendon reflex. Similar symptoms, but sensory loss will be over the lateral foot, sole of the foot, or small toes. There will be weakness of hip extension, plantar flexion of foot and the toes. Lumbar canal stenosis especially presents to us with neurogenic claudication, that is, exertional pain occurring over the thigh and the buttock with exercise intolerance and other symptoms. This is a table to differentiate between neurogenic claudication versus vascular claudication. Vascular claudication worsens with exertional pain. Same goes for neurogenic claudication, but vascular claudication is limited to the calf. There is a constant effect of exercise tolerance, and a bicycle will not reproduce the symptoms. Bicycling will not reproduce the symptoms in a neurogenic claudication, but will reproduce symptoms in vascular claudication. The pain in vascular claudication worsens while getting down. It increases on standing, and it may present to us with weakness on exertion. Paresthesias are rare in vascular claudications. The back hyperextension worsens symptoms in neurogenic claudications. Same goes for sitting. Sitting and leaning forward will resolve the symptoms. There is a prompt relief in vascular claudication, but the time for relief in neurogenic claudication is variable, lasting from 5 to 15 minutes. There are occasional sensory findings and reflex findings, and weaknesses often present after exercise. Peripheral pulses may be absent at rest or after exercise in vascular claudication. Moving on to peripheral nerves, it mainly consists of axons, dendrites, and nerve endings of sensory, motor, or autonomic
So,
nerves.
Dr. Ratnesh,
Yes, sir.
just to bring that point of neurogenic and vascular.
Yes, sir.
So, whenever there is leaning forward or this
Yes, sir.
neurogenic claudication, the history is in vascular, the activity stops and the patient feels better.
Yes, sir.
But in neurogenic claudication, patient usually stops and we have to ask, do you feel like sitting down and the symptoms are better or not?
Yes, sir.
Yeah. So what happens when they sit or when they flex? That intraforaminal, the gap, there is some gap present. So the neural compromise is reduced and they feel better.
Yes, sir.
Yeah.
Yes,
Yeah. Please proceed.
please. Lesions anywhere at the level of axons, dendrites, or nerve endings of sensory, motor, or autonomic nerves will cause peripheral neuropathy, sensory, motor, or autonomic. And lesions at the cell body in the spinal cord and the ganglia for the dorsal root ganglion and the autonomic ganglia, while motor neurons in the spinal cord will cause a neuronopathy or ganglionopathy. And I have included nodes and paranodes as well in the discussion. Yes. Moving on to histological organization. The nerve fascicles are bound together into nerve trunks by the epineuron, which is a loose areolar connective tissue that also contains the blood vessels, lymphatics, and the nervi nervorum. The epineuron also serves as an important cushioning role. The interfascicular epineuron lies between the fascicles, and the epifascicular epineuron circumferentially envelops the entire nerve. The intermediate layer, that is the perineuron, it surrounds individual fascicles, that is the bundles of nerve fiber, and it also plays a role in formation of the blood nerve barrier formed by the perineuron and the endothelium of the intrafascicular capillaries. This prevents toxins and immune cells from entering the nerve. The endoneuron is the innermost layer, which separates the individual axons and their Schwann cells. This is a Langer and Gasser classification of uh, for mixed peripheral nerves divided into group A, group B, and group C fibers. Group A fibers are further divided into group 1, group 2, and group 3. Group 1 afferent fibers are from annulospiral endings of the muscle spindles, that is 1A, and Golgi tendon, that is 1B. Group 2 are from the flower spray endings, the muscle spindles, and for the peripheral sensory receptors for touch and pressure, while group 3 are from pain and temperature receptors. The group 3 fibers carry fast pain, while group C fibers carry the slow and funicular and burning type of pain. Alpha fibers supply the extrafusal muscle fibers. Beta fibers are fewer in number, they supply extrafusal fibers and muscle spindles. And gamma fibers supply the intrafusal muscle fibers of the muscle spindles. Group B fibers are preganglionic autonomic. A and B are myelinated, while C can be partially myelinated or unmyelinated. The conduction speed is fastest in group A. After that comes group B, and after that comes group C. Group C are the slowest conducting. Another classification is Lloyd classification. Uh, A alpha fibers of the Erlanger and Gasser classification correlate to 1A of Lloyd classification, that is originating from muscle spindle and annulospiral endings. 1B is Golgi tendon organ. 2 is the muscle spindle flower spray ending touch pressure corresponding to A beta. A delta corresponds to 3 in the Lloyd classification, while the unmyelinated fibers are correspond to number 4, that is for pain, temperature, and other sensations. This is a simpler classification for type of nerve fibers. Large nerve fibers, A alpha uh, and A alpha or A beta, carry signals for muscle control, and they carry afferents for touch, vibration, position, and joint perception. While the thinly myelinated A delta fibers carry the cold perception and fast pain perception. Unmyelinated and thinly myelinated, unmyelinated fibers of the sensory nerves, they carry the warm perception and the slow pain. Autonomic fibers can be thinly myelinated or unmyelinated. They carry autonomic signals for heart rate, blood pressure, sweating, GIT, and GUT. Moving on to somatic sensory nerve endings, they are mechanoreceptors. That is for within the skin in the epidermis and dermis. That is, for example, Merkel's disc, Ruffini endings, Mason's corpuscles, Cross's corpuscles, hair and organs, and prenerve endings. For deep tissue sensations, it is Ruffini's endings, Pacini corpuscles, or free nerve endings. For muscle endings, there are muscle spindles and Golgi tendon receptors. The sound receptors of cochlea, equilibrium vestibular receptors. For arterial pressure, baroreceptors of carotid sinuses and aorta. Thermoreceptors are for cold and warm. Nociceptors are for pain, and electromagnetic receptors within the eye for vision, that is rods and cones. Chemoreceptors are for taste, for smell, osmolality, and other uh, chemicals and metabolites in the blood. So a short discussion on neuropathy. They are peripheral neuropathies are classically classified as demyelinating or axonal. This might be inadequate or misleading in some neuropathies. Thereby, Unsini et al. Proposed a new category of peripheral neuropathy, that is neuropathy. This was evidence from nerve conduction, excitability studies, and pathology, and in various animal models. It is characterized by a pathophysiological continuum from transitory nerve conduction to axonal degeneration. This conduction block may be due to paranodal myelin detachment, node lengthening, dysfunction or disruption of sodium channels, altered homeostasis of water and ions, or abnormal polarization of the axonal. This conduction block may be promptly reversible without the development of excessive temporal dispersion. Axonal degeneration, depending on the specific disorder and its severity, eventually follows the paranode. The uncompacted myelin loops are tightly attached, and at the internodes, the axons are surrounded by compact myelin. The centralmost part is the node, surrounded by paranodes, and as we can see, the areas covered by myelin are juxtanode and internode. The node has a high density of voltage gated sodium channels, and slow potassium channels, while the juxtaparanode has a high density of voltage-gated fast potassium channels. When the sodium gradient across the membrane is reversed, the exchanger can run in reverse mode, leading to increased intracellular calcium. The major clinical relevance for nodopathy and paranodopathy is the recently discovered antibodies against nodes and paranodes, that is NF155, Nurifacin NF186, Casper and contactin, and ankyrin G. And uh, these nodopathies have a slightly different presentation, and they have a slightly different response to treatment as compared to traditional demyelinating or axonal polyneuropathies. The main pathophysiology is disruption of the sodium channel, disruption or dysfunction of the sodium channels, which results in impairment of the generation of action potential current. Antibodies which bind at the node cause complement activation and membrane attack complex deposition. This results in a non-specific ion channel insertion and disruption of the membrane potential, which may result in a conduction block. Now, classical examples of nodopathies of peripheral nerve are GBS, CIDP, multifocal motor neuropathies, ischemic neuropathies, and toxin-induced neuropathies. Other neuropathies which are associated with anti-angioside antibodies are AMSTAR, PCB, MFS, and chronic ataxic neuropathy with diacylosine antibodies. Critical illness neuropathy is primarily axonal with a poor prognosis. More recently, critical ill patients who rapidly recovered from neuropathy with normalization of previously decreased CMAPs and SNAPs were discovered. They might be because of soluble factors released during sepsis, and this might act at the node or the paranodal region. Anti-NF155 antibody has been found in around 4 to 18% of patients with CIDP. The clinically homogeneous CIDP phenotype is more aggressive, more distal, motor predominant, associated with ataxia or tremor, and has a good response to rituximab, but not IVIG. Has a younger age at onset, has significantly higher CSF protein, which reflects potentially prominent spinal root involvement. This is the difference between classical CIDP and CIDP associated with the nodopathy. The fact that IgG4 subclass antibodies do not effectively fix complement suggests that anti-NF155 antibodies are likely to act by blocking interactions with the Casper contactin 1 complex. The pathological importance of these antibodies is further supported by the observation that IgG4 depletion with rituximab correlates with clinical recovery in CID. Anti-contactin 1 antibodies are associated with older age and aggressive disease onset, motor predominance, early axonal loss, and poor IVIG responsiveness. Anti-Casper antibodies, a predominant feature is neuropathic pain, and it is a direct consequence of the paranodal antibody binding. Genetic paranodopathies include CMT1A, CMT1C, and congenital hypomyelinating neuropathy. At the juxtaparanode, anti-Casper2 antibodies act. They specifically manifest with a combination of peripheral nerve hyperexcitability, that is cramps and fasciculation, either in isolation or as a part of disorder of acquired neuromyogenia, that is ISAC syndrome, as well as insomnia, limbic encephalitis, seizures, and dysautonomia. Why Casper2 antibodies selectively target the peripheral nerves remains unclear. Moving on to clinical approach to neuropathy. 7 key questions should be asked. The first question is whether motor sensory autonomic system is involved or there is a combination of symptoms. What is the distribution of weakness? Is it just distal or proximal and distal? Is it focal or asymmetric or is it symmetric? What is the nature of sensory involvement? Either it is a large fiber involvement or a small fiber involvement. A small fiber involvement would present with temperature loss, burning sensation, or a stabbing pain, and cotton wool sensations, while a large fiber involvement presents us with vibratory or proprioceptive loss. Is there evidence of upper motor neuron involvement? Is it with sensory loss or without sensory loss? What is the temporal evolution of the symptoms? Acute is days to 4 weeks, subacute is 4 to 8 weeks, and chronic is more than 8 weeks. We also have to see whether there is evidence of hereditary neuropathy. Is there a family history, or is there a lack of sensory symptoms despite sensory signs? This favors a hereditary neuropathy. We also have to assess for associated medical conditions, that is cancer, type 2 DM, connective tissue diseases, autoimmune diseases, and infections. Medications or over-the-counter drugs that may cause toxic neuropathy, herbal or toxins which may cause a peripheral neuropathy. Large fiber sensory symptoms. Sensory symptoms can be classified as either positive symptoms or negative symptoms. Negative symptoms are due to loss of function. Positive symptoms are due to disordered function of the sensory nerve and the sensory nerve receptors. Under large fiber neuropathies, the positive symptoms are paresthesias. The negative symptoms are loss of vibration, loss of proprioception, hyporeflexia, sensory ataxia. In small fiber neuropathies, there might be a loss of pain and temperature sensation, and there might be positive symptoms in the form of dysesthesia and anhedonia. In motor symptoms, the negative symptoms are wasting, hypotonia, weakness, hyporeflexia, and orthopedic deformity, while positive symptoms are cramps and fasciculations. Under autonomic symptoms, positive symptoms may be increased sweating and hypertension, while negative symptoms may be urinary retention, impotence, GI complaints, decreased sweating, or hypotension. Dysesthesia can be defined as unpleasant abnormal sensation, whether spontaneous or revoked. This includes hyperalgesia and anhedonia. Hyperalgesia is uh, sensation which is evoked. It is increased pain from a stimulus that normally provokes pain, while anhedonia is pain due to a stimulus which should not normally evoke pain. Anesthesia dolorosa is pain in an area or region which is anesthetic. Causalgia is the syndrome of burning, sustained burning pain, anhedonia, and hyperpathia after traumatic nerve lesion, often combined with vasomotor and pseudomotor dysfunction and later trophic changes. Hyperesthesia is increased sensitivity to stimulation, excluding the special sensation. Hyperpathia is abnormally painful reaction to a stimulus, especially a repetitive stimulus, as well as with increased threshold to pain. Hypoalgesia is decreased pain. Neuralgia is in a pain in the distribution of nerves or nerves. Paresthesia is abnormal sensation, and other terms are pain threshold and pain tolerance level. Moving on to the first question, that is the distribution of weakness, whether it is distal, proximal, or both. Is it focal and asymmetric or symmetric? Examples of symmetric, distal, and proximal weakness are immune-mediated polyneuropathies, which can be acute or chronic. For example, GBS and CIDP. Asymmetric, acute or subacute sensory and motor symptoms, as seen in radiculopathies, compressive mononeuropathies, mononeuritis multiplex should be considered. Examples of focal neuropathies are entrapment neuropathies, that is myxedema, rheumatoid arthritis, amyloidosis, and acromegaly. Compressive neuropathies, trauma, ischemic lesions due to uh, neuropathy due to the involvement of vasa nervosa by diabetes mellitus and vasculitis, leprosy, neurosarcoidosis, and infiltration of the nerve by any metastasis or any neoplastic infiltration. It should also be defined into certain patterns. A mononeuritis multiplex pattern can be due to axonal etiologies or demyelinating etiologies. Under axonal etiologies, it is vasculitis, type 2 DM, sarcoidosis, Hansen's disease, HIV, and leukemia. Demyelinating etiologies are multifocal motor neuropathy, multifocal acquired demyelinating sensory and axonal neuropathy, and compressive neuropathy or hereditary neuropathy with liability to pressure palsies. Predominantly motor polyneuropathies are GBS, Haman variant, CIDP, neuropathy due to hypoglycemia, hyperglycemia, lead toxicity, porphyria, multifocal motor neuropathy, osteosclerotic myeloma, diabetic radiculoplex, and hereditary motor and sensory neuropathy or organophosphate toxicity. Polyneuropathy with facial nerve involvement are GBS, neurosarcoidosis, HIV, Tanger's disease, Lyme's disease, CIDP, and Gelsolin familial amyloidosis. Neuropathies predominantly involving upper limb are MMN, MATSA, lead neuropathy, Tanger's disease, hereditary motor neuropathy, familial amyloid neuropathy, and porphyria. Neuropathies with autonomic involvement are acute and chronic. Acute are acute pan-dysautonomia, GBS, porphyria, vincristine and Vacor toxicity. Chronic autonomic neuropathies are type 2 diabetes, amyloidosis, paraneoplastic sensory neuropathy, that is anti-HU antibodies, HIV, and HSAN. Predominantly small fiber neuropathies will be type 2 diabetes, celiac, HIV, Fabry's disease, Sjogren's syndrome, amyloidosis, HSAN, Tanger's disease, and cryptogenic small fiber neuropathy, which is the most common cause of a small fiber neuropathy. Sensory ataxic neuropathies can be neuronopathies, chronic inflammatory sensory neuropathy, or demyelinating neuropathies. Under neuronopathies, anti-HU paraneoplastic neuropathy, Sjogren's syndrome, cisplatin toxicity, or excessive B6 consumption may cause ataxic neuropathy. Under demyelinating, MFS variant of GBS, IgM molecular gammopathy, anti-MAG antibodies, TAPES dorsalis, and Canomad, that is chronic ataxic neuropathy with ophthalmoplegia, IgM paratoproteinemia, cold agglutinin, and anti-GD1B diacylosine antibodies can cause neuropathy. Second question is the temporal evolution. That is, acute is from days to 4 weeks, can be vasculitis and AIDP. Subacute is mainly CIDP, and chronic, that is more than 8 weeks, is diabetes and hereditary. We also have to check whether the neuropathy is a monophasic neuropathy, a progressive neuropathy, or a relapsing neuropathy. GBS is usually monophasic, progressive are CIDP, and type 2 diabetes, while relapsing can be recurrent GBS or CIDP.
Can you just go back?
Yes,
This subacute you have mentioned CIDP.
yes,
Hello?
yes.
CIDP, what is the full form?
Sir, chronic, sir, this has been added by mistake, sir. More than 8 weeks
Okay.
is necessary
Yes.
for
So
CIDP.
maybe you wanted to write SIDP or something like that, subacute something. Chronic
Yes,
has
sir.
to be more than 8 weeks. Huh? Please take care.
Yes, sir. The other examples of subacute onset neuropathy are toxic agents, nutritional deficiency, abnormal metabolic state, or paraneoplastic syndrome, subacute inflammatory demyelinating polyneuropathy, and other neuropathies in relapsing or remitting course are porphyria, HIV, and toxic neuropathies. The common types of hereditary neuropathies are CMT, hereditary neuropathy with laboratory pressure palsies, hereditary neurologic amyotrophy, HSAN, Fabry's disease, Repsom's, Ganges disease, porphyria and family amyloid polyneuropathy. We also have to check whether the patient has any associated medical condition, that is type 2 diabetes, SLE, anemia, any preceding or concurrent infections, that is diarrhea, any history of any surgeries which may predispose to a nutritional neuropathy, any medications which may cause toxic neuropathy, that is cisplatin, chemotherapeutic agents, vitamin B6, antiretroviral therapies. We have to check for that. We have to ask for history of alcohol consumption, dietary habits, and history of any dental fixatures. Zinc might cause copper deficiency, which might cause further neuropathy. There might be certain clues to a clinical diagnosis. Viral illnesses in the case of GBS and CIDP, lifestyle, work, and occupational exposure for toxic neuropathies, alcohol abuse, vitamin deficiencies, dietary habits, use of drugs, surgeries, history of surgeries, HIV infection, type 2 diabetes, previous diseases, malignancy, connective tissue disorders. All these history should be uh, checked for in a patient with neuropathy. Moving on to toxic neuropathies, the drugs causing neuropathies can be divided as axonal demyelinating or neuronopathy, vincristine, paclitaxel, nitric oxide, colchicine, isoniazid, hydrolazine, metronidazole, pyridoxine, and chloroquine can cause axonal polyneuropathy. Amiodarone, chloroquine, and gold causes predominantly demyelinating polyneuropathy. And thalidomide, cisplatin, and pyridoxine cause neuronopathy. Uh, Similarly, chemotherapeutic agents, thalidomide, disulfiram, and pyridoxine may cause a sensory neuropathy. Dapsone and lead may cause a motor neuropathy. And vincristine, vinblastine, cytarabine, metronidazole, and amiodarone can cause a mixed type of neuropathy. Neuropathies with characteristic painful polyneuropathies, diabetes, pre-diabetes, alcohol, chemotherapy, uh, paraproteinemia, vasculitis and connective tissue diseases, heavy metals and other toxins, HIV, amyloidosis, and porphyria. Certain signs which are important are early signs may be distant sensory loss to cold, pinprick, or vibration, reduced or lost ankle reflex, Romberg sign, impaired tandem walking, toe extension weakness, and later features are Digital loss of cold pinprick vibration sensation. It reflects a foot drop and ability to provide involve. Neuropathies with skin, nail, or hair manifestations. Vasculitis can have purpura or livedo reticularis. Meese lines can be seen in arsenic or thallium poisoning. Alopecia can be seen in thallium poisoning. Purpura may also occur in cryoglobulinemia. There might be anesthetic hypopigmented patches in leprosy. Worm syndrome may present to us with skin hyperpigmentation or hypertrichosis. There might be diffuse angiokeratomas all over the body in Fabry's disease and ocular telangiectasias and attacks of telangiectasia. Giant axonal neuropathy may have called hair. These are photos of livedo reticularis and purpura. Angiokeratomas, skin pigmentation for leprosy.
Dr. Ratnesh, your voice is not audible.
Maybe some coverage issue.
Hello. So meanwhile, Dr. Ratnesh is joining. We can just discuss quickly about radiculopathy. There are two, three maneuvers. I think we all should know that Sperling maneuver is there. If if we flex the neck laterally and press it downwards, there can be reproduction of the symptoms. The symptoms will reappear. That is in cervical radiculopathy. Lower limb, we all know that straight leg raise or Lezet test can cause appearance of the symptoms. And we should also ask about this symptoms of Valsalva, like whenever there is coughing or sneezing, or whenever they try to exert a pressure like lifting weight or straining at stools and all that, also kind of increase the symptoms or not. So if there is any such history that favors that this Valsalva kind of maneuvers, they reproduce the symptoms, means it is more of an intraspinal pathology, not like some peripheral pathology. That we have to remember. And I think he also mentioned about causalgia. So there people might ask about what is complex regional CRPS types and all that. So one is without injury and one is with peripheral nerve injury. So causalgia is usually with the nerve injury, that we should know. And CRPS also they might ask what is the warm type, what is the cold type. So warm is something where the skin is warm and cold is where the skin is cold type. I think he is joined. Hello,
Yeah, he is joining.
Dr. Ratnesh has joined.
Yeah, he joined. No, voice is not there.
I think voice is not audible. Dr. Ratnesh.
Yes, sir. Am I audible, sir?
Yeah, now it is audible.
Yes.
Can you just go back to the previous slide?
Yes, sir.
Yeah, I think, yes.
Yes.
In the hair, we should also know that this, I think, main case disease, they have this kinky hair appearance,
Yes, sir.
which is usually like a refractile hair and sparse hair. That we have to remember.
Yes, sir. Menkes kinky hair syndrome.
Yeah, correct. And this tick bite, no, sometimes the area where the tick is stuck, there will be small alopecia surrounding that also. That could be there. That also we have to remember.
Okay, sir.
Okay, you proceed.
Yes, sir. Neuropathies with cranial involvement are Miller-Fisher syndrome, that is external ophthalmoplegia, trigeminal sensory loss and Sjogren syndrome, lower cranial nerve palsy with gynecomastia, that is Kennedy syndrome, GBS, leprosy, Lyme's disease, sarcoidosis, and HIV may have facial nerve palsy. Hi,
So
sir.
here we should, yeah.
Yes, sir.
In
Sir,
facial palsy, leprosy, they will ask, what is the peculiarity?
sir, skin changes may be there. There might be hypopigmented anesthetic patches, and
No, it may have isolated upper facial involvement.
okay, sir.
Okay, yeah, proceed.
Yes. So these are the foot deformities and hand deformities seen in long-standing acquired or hereditary neuropathies. Pes cavus, hammer toes, and claw hand deformity can be seen. So this is the inverted champagne bottle appearance of hereditary neuropathies. We also should check for nerve thickening. That is, palpation of peripheral nerves should be done. A single nerve trunk hypertrophy would suggest a neoplastic process, that is neurofibroma, schwannoma, or a malignant nerve sheath tumor, or a localized perineural hypertrophic neuropathy. Generalized or multifocal nerve hypertrophy is found in neurofibromatosis, CMT types 1 and 3, acromegaly, reference disease, and rarely CIDP. Also, very important is leprosy, the most common acquired cause of nerve hypertrophy with neuropathy. Peripheral nerve palpation should be done at posterior auricular areas, the greater auricular nerve, the ulnar nerve, the radial nerve at the anatomical snuff box, and the superficial peroneal nerve, as well as the nerves in the popliteal fossa. Motor system changes in
For
axonal
this
neuropathy.
high arched pes cavus, they might ask how to examine that. So that, could you please tell us?
Yes, sir. So examination of pes cavus, we have to ask the patient to stand upright with the feet on the floor. If there is a distance of around more than 3 centimeters, or a simple clinical test can be, we can insert two, if the patient, if there can be insertion of more, two or more than or equal to two fingers in between the ground and the arch of the foot, then it can be considered as pes cavus.
No, as far as I remember, you have to ask the patient to put the foot on the flat surface. It can be on the floor or you can put it on the stool also. And you just see through and through. If you are able to see through and through, that means there is a gap. That is a pes cavus.
Yes, sir.
Or some people might use the light whether it is passing or not. If you are seeing through that arch, means there is a gap. That is the pes cavus.
Yes, sir.
If you're not able to see through and through, that means there is no such base case.
Yes, sir.
Okay.
Motor system changes. In axonal neuropathy, there is a prominent and early wasting and atrophy. And in demyelinating neuropathy, there is a less diffuse wasting as compared to axonal type. The wasting may occur, but it occurs later in the stages of the disease. There is a claw hand deformity in leprosy, diabetes, and amyloidosis. And there might be foot deformities in CMT, HSAN, and HMSN. Trophic changes can be seen in long-standing diabetic neuropathy, leprosy neuropathy, and hereditary neuropathies. So important points in reflex examination are the reflexes are usually diminished or absent, especially ankle jerk. But in certain conditions, there might be exaggerated knee jerk with ankle absent, that is B12 deficiency, HIV, myeloneuropathy, and Friedreich's ataxia, the variant of Friedreich's ataxia with retained reflexes, that is FARR. And along with that, Friedreich's ataxia may also have extensor plantar reflex with absent or diminished knee jerk and ankle jerk. Along with that, patient may have sensory ataxia, high stepping gaits. RS examination, certain points to be looked for: asthma and Church-Strauss syndrome, sarcoidosis, HIV, TB, CA lung, and connective tissue disorders. For cardiovascular system, you have to check for cardiomyopathy, especially in case of diphtheria, alcohol toxicity, and amyloidosis, and pericarditis for connective tissue disorders. For abdomen examination, to look for hepatosplenomegaly, and abdominal tenderness may be seen in porphyrias and toxins such as lead and thallium. Ophthalmic examination should be done for cataracts, diabetes, microaneurysms, optic disc edema, especially in AIDP, CIDP poems, xerophthalmia in case of Sjogren syndrome and sarcoidosis, and ocular telangiectasias in case of ataxia telangiectasia and ataxia telangiectasia-like disorders. Blood investigations, we should do a complete
Before
blood count.
that, would you like to see pupils and all?
Yes, sir. Pupils should be looked for to rule out any concomitant central and peripheral neuropathy, and to look for cataracts should also be looked for. And along with that, sir, we should look for a KF ring to rule out Wilson's disease.
So any particular neuropathies where pupil can be involved? Botulism you have to remember.
Yes, sir.
All these dysautonomic syndromes you have to remember.
Yes, sir.
And hereditary neuropathy, though we feel that neuropathy usually is not involving pupils, CMT sometimes, some types, subtypes can have pupillary involvement. They
Yes.
may have a poor reaction or delayed reaction also,
Yes, sir.
right? And
Yes.
even the GBS variants, including Miller-Fisher, we have to remember. Pupil we have to examine.
Okay, sir.
And I think disc edema you have mentioned. Gait, you could have told something more. I think that was a backslide. Yeah.
Yes, sir.
So any gates you should have told. Like one more thing, this B12 deficiency, similarly, this copper deficiency myeloneuropathy will be similar to that.
Yes, sir.
That is one more DD we should have. Gate, could you please tell more about gate?
Sir, mainly there is a sensory ataxia. The gait is wide based with irregular stride. The stride length is not fixed; it might be irregular, and the gait can be staggering. The gait is usually high steppage because
Usually
of.
sensory ataxia, the vision is a cue.
Yes, sir.
So unless there is a very, very, very severe sensory ataxia, that those things will not be happening because patient will have the visual cue as a help,
Okay, sir.
right? So only when there is that is called as rhombergism. Only when there is eyes are closed or the lights are dim or visual cue is taken away, patient will have a bad stance or bad gait,
Yes, sir.
especially poor lit areas, evening times. That we have to tell. So
Yes.
what history patient will give, like when, what are the common scenarios when the patient will have such poor vision?
Sensory ataxia might worsen during the evening times or at night times when the patient gets up to go to the washroom. Before starting light, the patient may have an increased tendency to fall or an increased imbalance. And while approaching the wash basin, if the patient is washing his face, if at that time when the patient closes the eyes, there might be a swaying to either side, that is, which is also known as wash basin ataxia.
Correct. So whenever there is eye closure, so what are the other scenarios where the eyes are closed or the eye vision is kind of obscured? Whenever they are taking, let's say they are taking the kurta or t-shirt out, that time the vision will get blocked.
Yes, sir.
Second, while putting soap or something on the face. Third, if they are praying with eyes closed. So all these
Yes.
scenarios, patient, yes, somebody has mentioned. So all these scenarios we have to ask because these are real life scenarios where
Yes.
patient will have rhombergism.
Yes, sir.
What other gates can you tell us?
Sir, high steppage gait is due to weakness of the distal muscles of the foot. There is a weakness of a dorsiflexion, which results in the patient compensating by having
Correct. In the
exaggerated
case
flexion
of
at the
foot
hip.
drop, basically.
Yes, sir.
And what other gaits?
Sir, if there is a uh, weakness of the hip, if the neuropathy extends further, there is a severe and extensive neuropathy, there might be waddling gait due to involvement of hip extensors, although it is very rare, sir.
That is usually in myopathy.
Myopathies,
Yes.
yes, sir.
What is stamping or stomping gait?
Sir, as during the stance phase, the patient is unable to maintain a smooth movement from heel to toe, and because of weakness of dorsiflexors, the foot suddenly stamps down on the ground, resulting in
No.
stamping
So
gait.
wherever there is proprioception is weak, they put the foot very forcibly down, like a stamping or stomping. That
Yes,
is to get that proprioception, right? So
yes,
in Tabes dorsalis or all these B12 patients, if they are very severe, they have this stamping gait. They forcefully, almost like a banging the foot on the floor. That is called as stamping gait or stomping gait.
yes, sir.
Yeah.
Yes,
Okay. Then next.
yes.
In sensory examination, you just mentioned reflexes.
No, sir. We also have to assess for fine touch, crude
What
touch,
is the backslide to this? Maybe I missed it.
sir, motor system.
Okay. So you have to mention these things you have to mention.
Yes,
Sensory, how will you proceed?
sir, we have to assess different modalities. The first modality will be, sir, fine touch. The second modality will be crude touch. That the third will be hot and cold sensation. Fourth will be vibration, and fifth will be sir, joint
So how will you
position
check
sense.
hot and cold sensation?
Yes, sir. Sir, we'll take two test tubes, sir. One test tube will be containing cold water. One will be containing hot water. The patient will be asked to close his eyes and
What should be the temperature of hot and cold?
6 to 10 degrees, 40 to 45 degrees.
yes, sir.
Sorry? Uh, has it been discussed already? Somebody is trying to say that, or has it been discussed already?
No, sir.
Okay. So what should be the temperature? Hot and cold?
The exact values, I don't remember, sir. Around 40, 42 degrees, sir, for hot, and around 20 to around 25 degrees for cold water, sir.
No. So it is around 5 and 40. You have to remember that number.
Okay, sir.
Okay.
Okay, sir.
I think you should please read Dijon for that.
Yes, sir.
And yes, what else?
And sir, for fine touch, we are supposed to use a wisp of cotton and ask the patient whether the patient is able to feel the movement of the wisp of cotton or not. And for pinprick sensation, we are supposed to use the uh, fine pin and ask the patient whether the patient can feel a pinprick. For vibration sense, we are supposed to check at the great toe, at the thumb, at the ankle, knee joint. For example, if the vibration is impaired at the great toe, we have to check further upwards and upwards to decide the level at which it gets normalized. And for same goes
But
for
how?
vibration sense.
What is the normal value? How will you say that vibration is gone?
Sir, for more, if there is sensory loss before around 50, sorry, if there is patient is unable to feel the vibration after 12 seconds, it is considered as vibration loss.
If he's feeling no. So normally, when we put it on great toe, 15 seconds. Yes, somebody has put it. For 15 seconds, normally we should be able to feel it for
Yes,
a normal adult person. But as you age, let's say beyond 40 or 50, there is almost 1 second decrement in that vibration sense every
yes.
decade. So anybody who's got less than 10-second vibration field, you have to take it as abnormal.
Okay, sir.
For any age, 10-second cutoff you can take,
Okay, sir.
right?
Yes.
Yeah.
And yes, sir. vibration, joint
Yes.
position, hot and cold, croup touch and fine touch and pinprick should be assessed.
Mhm.
Yes.
You have mentioned here trophic. What is the meaning of trophic?
Sir, as the nerve just does not supply, it also supplies, it is also responsible for the nutrition and maintenance of normal structure of the tissue. Because of loss of nerve growth factors and other factors which are released from the nerve terminals, there is gradual decrease in blood supply and resultant trophic changes of the
Correct,
skin,
correct.
tight,
So
shiny skin.
trophy means nutrition. Trophy
Yes,
word stands for nutrition.
yes, sir.
So that you should remember.
Yes, sir. Loss of nutrition, either due to a loss of growth factors from the nerve or due to loss of a proper blood supply, may result in thin, shiny skin, a tight skin, loss of the hairs, and skin changes in the form of ichthyosis or darkening of the skin.
Usually trophic ulcers and all in long term.
Yes,
Then next slide.
yes. Sir, we should also look for certain points on examination of respiratory system and examination of cardiovascular system. Churg-Strauss syndrome will have asthma. Neurosarcoidosis may have system findings in RS system. It could either be findings on auscultation, findings on chest X-ray. We have to also rule out involvement of TB or HIV, CA lung or connective tissue disorders. Diphtheria, alcohol, and amyloidosis may have cardiomyopathy, and connective tissue disorders, especially SLE, can also present to us with pericarditis. Hepatosplenomegaly can be present in HIV, lymphoma, connective tissue disorders, paraneoplastic neuropathies, and amyloidosis. Tenderness may be present in porphyria, neuropathies due to porphyria, toxins such as lead and thallium. Ophthalmic examination should be done, including pupillary examination, examination for ocular telangiectasias, cataracts, microaneurysms, optic disc edema, and xerophthalmia. Sir, routine blood investigations, including full CBC count, ESR, CRP, renal function test, liver function test, RBS, HbA1c, serum protein electrophoresis to look for any paraproteinemias. Autoantibodies, that is ANA, anti-ganglioside and anti-neuronal antibodies should be checked. B12 level should be checked. And if indicated, copper and ceruloplasmin levels can also be sent. DNA analysis for hereditary neuropathies, that is chromosome 17 duplication in case of HMSN1 and 1A, and chromosome 17 deletion in case of HNPP. We should also test for urine for Benz-Jones proteins, urine for porphyria also it should be checked, that is urine for porphobilinogens. Heavy metal screening should be done in the urine. CSF analysis to look for sugar, the cell count, differential cell count, and CSF protein. Also, we should check for CSF, RPR or CSF VDRL in case of suspected neurosyphilis. CSF TPH can also be done. And we should also check for any other infective etiologies. Nerve conduction studies, EMG, and sensory examination should be done. Should do imaging, autonomic function tests, and important diagnostic tests for other conditions. Nerve biopsy is indicated for vasculitis, amyloid neuropathy,
Can you mention about some autonomic tests?
Yes, sir. Sir, autonomic function tests are, first of all, is, sir, fall of postural blood pressure. The patient is asked to, first we check for a blood pressure reading in the supine position. When the patient has maintained the supine position for 5 minutes, we check for the supine position of blood pressure. Then we ask the patient to stand up. We check the blood pressure at 1 minute and at 3 minutes after standing. If there is a significant postural drop of more than 20 millimeters of mercury on systolic blood pressure, then it is considered as a significant postural fall. Other tests are heart rate variability on deep breathing, and quantitative, the QSAR test, tilt table test, and variability on ECG should also be checked for as part of autonomic function test.
Okay, and something called as test on Valsalva maneuver.
Yes, sir. On the heart rate variability and beat to beat variability should be checked on ECG as well as on peripheral pulse for after asking the patient to do a Valsalva maneuver.
Okay, heart rate variability we cannot check bedside. That needs a very high-end instrument. Bedside, what all things we can check? We should check that.
Yes, sir.
So, if you put the hand in the water, we usually expect uh, the rugae or the foldings to develop. But somebody who's not developing, that could be the reason because of the autonomic dysfunction. Then, with the Valsalva, we have one more thing. Cold immersion, we have one more thing. Uh, this QSART and all that we have to do. These are all research-based tests. Sustained hand grip is one of the things. This we all should know. I think there is a good chapter on. I think in Dijon they have got this thing for sustained hand grip and dynamometer. How should we do that using a simple blood pressure machine, mercury manometer? We should know. Please read about it.
Yes.
Yeah.
Nerve biopsies should be done for suspected vasculitis, amyloideuropathy, leprosy, CIDP, and inherited disorders of myelin and rare axonopathies. The most commonly selected nerve is sural nerve. Alternative is a superficial peroneal nerve, but uh, and along with that, we should also do a simultaneous biopsy of the peroneus brevis muscle through the same incision for a better result. The combined nerve and muscle biopsy increases the chance of identifying a suspected vasculitis. Sir, this is a flowchart from Harrison. History and examination, if it is compatible with neuropathy, we should classify it into patterns: mononeuropathy, multiplex, polyneuropathy, further, we should do electrodiagnostic studies. After that, if it is a suspected vasculitis, I should do a nerve biopsy. If it is a suspected CIDP, we should test for paraproteins, HIV, and Lyme's. If it is a suspected axonal subacute demyelinating polyneuropathy, we should test for toxins. If it is a chronic, we should review family history and test for paraproteins if it is a demyelinating one. And for suspected GBS and CIDP, should treat accordingly IVIG or plasmapheresis or further immunosuppression for CIDP. So these are clinical signs. Hand of benediction or benediction posture is when asking the patient to hold the hand as a straight. The ring and little fingers are clawed with the metacarpophalangeal joints hyperextended and proximal and distal interphalangeal joints flexed from the third and fourth lumbricals, while fingers and thumb are held slightly abducted. Wartenberg sign is recognized as passively abducted little finger due to weakness of the third palmar interosseous muscle. The Froment sign occurs when patient attempts to pinch an object or piece of paper. To compensate for intrinsic muscle ulnar hand weakness, the long flexors of the thumb and index finger are used, which create a flexed thumb and index finger posture. This is seen in ulnar nerve palsy. While hand of benediction is seen in weakness of the third and fourth interphalangeal joints, third and fourth lumbricals. This is Froment sign. We can see that the patient is using the long flexors of the thumb and the index finger to hold the cardboard or a piece of paper. On asking the patient to make a closed fist, if there is a weakness of ulnar flexor distorum profundus, the patient may be unable to make a fist properly, resulting in slightly outward movement, outward positioning of the nails, as we can see on the right hand of the patient. This is sensory loss. We should also check for patterns of sensory loss. Sensory loss in ulnar neuropathy is in the medial aspect of the hand, that is the little finger and the medial half of the ring finger. So this is for factors differentiating for suspected ulnar neuropathy. These are innervations by the median nerve. It innervates the pronator teres. That is the main main median nerve arising from lateral cord. It supplies the pronator teres, flexor carpi radialis, and flexor distorum subliminis. The anterior interosseous nerve supplies FDP 2 and 3, flexor pollicis longus, and pronator quadratus. The recurrent thenar branch of the median nerve supplies the APB, the opponens pollicis, and the flexor pollicis brevis. The sensory supply of the median nerve is by a palmar cutaneous branch that supplies the thenar eminence, the digital branch which supplies the medial thumb, index finger, and middle finger, and lateral fingers, ring finger is also supplied by the median branch, the distal branch of the median nerve. This is high median neuropathy hand posture. A complete high median neuropathy results in a classic hand posture. The patient attempts to make a grip. The patient is unable to flex the thumb, index, and middle fingers. AI neuropathy, weakness of the flexor pollicis longus, results in the patient being unable to make an OK sign. The thumb and index finger are unable to flex at IP joints and the DIP joints respectively, resulting in a quadrilateral shape appearance rather than a normal circle shape appearance. This is signs and symptoms which are highly suggestive of a carpal tunnel syndrome, that is low median neuropathy, nocturnal paresthesias, shaking or wringing of the hands, pain or paresthesia associated with driving, sensory disturbances of digit 1, 2, 3, 4, weakness and wasting of thenar eminence or Phelan's maneuver. This is the typical median sensory territory. The first is the palmar distal sensory branches, and the second is the palmar cutaneous sensory branch of median nerve. This is symptoms and signs for carpal tunnel syndrome. The pain of the hand and wrist is associated with tingling and numbness, classically distributed along the median nerve. The patient wakes up at night with burning or aching pain and shakes the hand to obtain relief sensation. There is a thenar atrophy and weakness of thumb opposition and abduction in late stages. So this is for clinical differentiating factors in wrist drop. PIN neuropathy will have wrist drop or finger drop and radial deviation on wrist extension. Neuropathy of radial nerve at spiral groove will have wrist drop or finger drop, weakness of supination, elbow flexion, or diminished brachioradialis tendon reflex with sensory loss in the lateral dorsal hand. Involvement of radial nerve at axilla will have involvement of the wrist, supination weakness, elbow flexion weakness, diminished brachioradialis tendon reflex, weakness of elbow extension, shoulder abduction. Shoulder abduction will be spared, but if there is a lesion at posterior cord, the shoulder abduction will be involved. So this is for involvement of radial nerve at various places. This we discussed previously, sir. Root injury, cervical and lumbar, and sacral. These are images for the dermatomes and the areas supplied by the particular branches of the peripheral nerves. So these are muscles supplied by various peripheral nerves and the root values. So I would like to take a very brief approach on myopathy. So shall I proceed forward, sir?
Yeah.
Yes. The first goal in approaching a patient with suspected muscle disease is to determine the correct site of lesion. The second goal is to determine the cause of myopathy. And third is to determine whether a specific treatment is available or not, and optimally manage the patient's symptoms and to maximize his or her functional abilities and enhance the quality of life. Myopathies can be classified as hereditary or acquired. Hereditary myopathies are dystrophies, myotonias, channelopathies, congenital myopathies, metabolic myopathies, and mitochondrial myopathies. Acquired myopathies are inflammatory, endocrine, myopathies associated with systemic illness, drug-induced or toxic myopathies. A clinical evaluation should include history, examination, and investigations. Under history, similar to peripheral neuropathy, we should check what is the distribution of weakness. Is there any significant family history? Are there any associated systemic symptoms or signs? If there are any, which negative or positive symptoms and signs does the patient demonstrate? What is the temporal evolution? And are there any precipitating factors which trigger episodic weakness or myotonia? Negative symptoms in case of myopathy are weakness, fatigue, exercise intolerance, and muscle atrophy. As per history, patient will have a difficulty climbing stairs, arising from a low chair or toilet and getting up from a squatted position in proximal lower extremity weakness. Proximal upper extremity weakness will have trouble lifting the objects overhead and brushing their hair. Distal upper extremity weakness will present with difficulty opening jars, inability to turn a key, and lower extremity weakness will present with a foot drop, while cranial muscle weakness may present with dysarthria, dysphagia, or ptosis. Fatigue is a less useful negative symptom. It is non-specific, and abnormal fatigability after exercise can result from certain metabolic and mitochondrial myopathies, and it is important to define the duration and intensity of exercise that provokes the fatigue. Myalgia is another non-specific symptom. If it is episodic, it favors a metabolic myopathy. If it is constant, it may favor an inflammatory muscle disorder. It is more likely to be due to orthopedic or rheumatological disorders. Cramps are typically benign, occur frequently in normal individuals, and are seldom a feature of primary myopathy. But if they occur, it can occur with dehydration, hyponatremia, azotemia, mixed edema, or disorders of the nerve or motor neuron, especially ALS. The difference between cramps and contractures are the cramp is a temporary condition while contractures are fixed. Contractures are electrophysiologically silent while cramps are electrophysiologically active. Contractures can be provoked or unprovoked, can be fixed or dynamic. The dynamic contractures are typically provoked by exercise in patients with glycolytic enzyme defects. The myopathies which present with muscle contractures are glycolytic or glycogenolytic enzyme defects, that is myophosphorylase deficiency, PFK deficiency, PGK deficiency, phosphoglycerate mutase deficiency, LDH deficiency, and D-branched enzyme deficiency. And paramyotonia congenita, hypothyroid myopathy, Brody's disease, and rippling muscle disease. Myotonia is the phenomenon of impaired relaxation of muscle after forceful voluntary contraction and most commonly involves the hands and eyelids. Myotonia is due to repeated depolarization of the muscle membrane. Patient may complain of muscle stiffness or tightness resulting in difficulty releasing hand grip after a handshake, unscrewing a bottle top, or opening their eyelids if they forcefully shut their eyes. Myotonia classically improves with repeated exercise. Paramyotonia congenita or paradoxical myotonia is in which the symptoms are typically worsened by exercise or repeated muscle contractions. Exposure to cold results in worsening of both myotonia and paramyotonia. The myopathies associated with muscle stiffness are myotonic dystrophy, proximal myotonic dystrophy, myotonia congenita, paramyotonia congenita, hypokalemic periodic paralysis, or hypothyroid myopathy. Myoglobinuria is an uncommon manifestation of muscle disease. It is caused by excessive release of myoglobin from the muscle during periods of rapid muscle destruction. Severe myoglobinuria can result in renal failure and acute tubular necrosis. Patients present to us with cola-colored or red-colored urine. It's usually due to underlying metabolic myopathy. These are various causes of myoglobinuria: drugs, toxin, neuroleptic malignant syndrome, heat stroke, trauma, metabolic myopathies, and rare causes are malignant hyperthermia and LGMD. Physiologically, it is common after prolonged and intensive exercise and after viral and bacterial infections also it can be seen. Moving on to temporal evolution, we have to see for the onset, the duration, and the evolution of patient symptoms. Myopathies presenting at birth are congenital myotonic dystrophy, centronuclear myopathy, congenital fiber type disproportion, central core disease, Nemelin myopathy, congenital muscular dystrophy, lipid storage diseases, glycogen storage diseases. In childhood, DMD, BMD, EDMD commonly present, less commonly FSHD, LGMD, and congenital myopathy may present. DM and PM, that is dermatomyositis and polymyositis, may present in childhood, but it is rare. Congenital myopathies such as Nemelin, centronuclear, central core can also present during childhood. Adulthood presenting myopathies are muscular dystrophies, inflammatory myopathies, and metabolic myopathies. Under muscular dystrophies, LGMD, FSHD, Becker's muscular dystrophy, and EDMD. Under inflammatory, polymyositis, dermatomyositis, inclusion body myositis, and HIV-related viral myopathy. Metabolic myopathies are acid maltase deficiency, lipid storage diseases, D branch deficiency, and phosphorylase B kinase deficiency. We also have to ask for history of episodic periods of weakness with normal strength, which can be seen in periodic paralysis and metabolic myopathies, or the patient may have a constant weakness in the other disorders, that is dystrophies and dystrophinopathies. The constant weakness may be of acute or a subacute progression, that is inflammatory myopathies, dermatomyositis, and polymyositis, chronic slow progression over many years in most muscular dystrophies and inclusion body myositis. Non-progressive weakness with little change over decades is seen in congenital myopathies. Polymyositis can occasionally have an acute monophasic course with complete resolution of strength within weeks or months. Many patients with periodic paralysis or metabolic myopathies can have recurrent attacks of weakness over many years, and acute rhabdomyolysis due to cocaine may have a single episode. Illegal drugs or prescription medication use may produce a myopathy. Weakness, pain, or myoglobinuria may be provoked by exercise, and fever may also precipitate episodes of weakness, especially in CPT deficiency, that is carnitine palmitoyl transferase deficiency. Ingestion of excessive carbohydrates or exercise may provoke weakness and periodic paralysis. And patients with paramyotonia congenita frequently report that cold exposure precipitates their symptoms of muscle stiffness. Associated symptoms in myopathies are arrhythmias, that is seen in Kearns-Sayre syndrome, Anderson syndrome, polymyositis, muscular dystrophies, that is myotonic dystrophy, LGMD, and EDMD. Myopathies with respiratory insufficiency are DMD, BMD, EDMD, LGMD, myotonic dystrophy, and congenital myopathy. Metabolic myopathies may also have respiratory insufficiencies. Hepatosplenomegaly may be seen in myopathies associated with deficiencies in acid maltase and debranching enzyme, infectious diseases, and mitochondrial disorders. Thorough family history should be asked and a family tree should be made. X-linked dominant inheritance is seen in DMD, BMD, and EDMD. Autosomal dominant inheritance is seen in FSHD, LGMD, OPMD, myotonic dystrophy, and periodic paralysis. Rest all other LGMDs are mainly autosomal recessive. The MRC council should be used for the grading of the muscle strength. We should also check for inspection, that is selective atrophy and of the quadriceps and forearm flexor weakness. Selective atrophy of quadriceps and forearm flexor muscles is highly suggestive of IBM. Distal myopathies may have profound atrophy of the anterior or posterior lower extremity compartments. And hypertrophy is seen in LGMD 2C to 2F, LGMD 2I, especially calf hypertrophy. Calf hypertrophy can be seen in myotonia congenita. Hypertrophy of the other muscles can also be seen in myotonia congenita. Amyloidosis may present with hypertrophy. Sarcoid and hypothyroid myopathy can present with pseudohypertrophy. DMD and BMD may also present to us with pseudohypertrophy. So these are the history points for functional assessment of muscle weakness. So this is an algorithm for approach to muscle diseases as we discussed. The first pattern is proximal limb girdle weakness. This is seen in hereditary myopathies, acquired myopathies, and dystrophinopathies. Distal weakness involves predominantly muscles of the distal muscles of the upper limb or lower limb, could be anterior muscle groups or posterior muscle groups. Involvement is usually, although not invariably, symmetrical. Myopathies with predominantly distal weakness are late adult onset distal myopathy, Welander type, late adult onset distal myopathy type 2, that is the Marcus-Berry myopathy, Nonaka myopathy, Miyoshi myopathy, and Lang myopathy. Desmin myopathy and childhood onset distal myopathy may have a distal predominant presentation. Other myopathies are myotonic dystrophy, FSHD, scapuloperoneal myopathy, OPMD, and inflammatory myopathy. Especially, IBM should be considered as an important differential in a distal predominant weakness. Proximal arm or distal leg weakness is also another pattern, the third pattern. This is also known as a scapuloperoneal pattern. Scapuloperoneal pattern can be seen in scapuloperoneal muscular dystrophy, EDMD, LGMD1B, 2A, and 2C to 2F, Nemeline myopathy, central core myopathy, and acid maltase deficiency. If this pattern has associated facial weakness, we should put FSHD as an important differential. Distal arm or proximal leg weakness is essentially pathognomonic for IBM and may also be an uncommon presentation of myotonic dystrophy. In here, there is distal arm weakness involving the wrist and finger flexors and proximal leg weakness involving the knee extensors. Myopathies can also present with ptosis with or without external ophthalmoplegia. These may occur with symptoms of diplopia. Facial weakness is not uncommon and extremity weakness is extremely variable depending on the diagnosis. This is seen in oculopharyngeal muscular dystrophy, mitochondrial myopathy, especially CPEO, and CPEO, Kearns-Sayre syndrome, and is also ptosis and facial weakness without ophthalmoplegia is a common feature of myotonic dystrophy. Myopathies with ptosis or ophthalmoplegia are myotonic dystrophy, congenital myopathies, and Desmin myopathy. Without ophthalmoplegia. With ophthalmoplegia are OPMD, oculopharyngeal myopathy, CPEO, and neuromuscular junction disease. Pattern 6 is prominent neck extensor weakness, that is dropped head syndrome. It is seen in amyotrophic lateral sclerosis and myasthenia gravis, or it can also be seen in isolated neck extensor weakness myopathy. Myopathies with prominent neck extensor weakness are isolated neck extensor myopathy, polymyositis, dermatomyositis, IBM, carnitine deficiency, FSSD, myotonic dystrophy, and congenital myopathy. So these are basic lab and electrophysiological investigations which should be done. After detailed evaluation, we should also go for genetic testing or muscle biopsy. Markedly elevated CK can be seen in LGMD1C, that is caveolopathy, LGMD2A, that is a calpainopathy, and LGMD2B, that is a dysphalinopathy. CK level may not be elevated in myopathy associated with corticosteroid use, collagen diseases, alcoholism, hyperthyroidism, and profound muscle wasting. For muscle biopsy, the selection of the appropriate muscle is to biopsy is critical. Muscles that are severely weak, that is MRC grade 3 or less, should not be biopsies, as they are less likely to show active disease, or they might only show evidence of end stage disease. Muscles that have been recently studied by needle AMG should be avoided because of possibility of artifacts created by needle insertion. It should be taken from muscles that demonstrate MRC grade 4 strength. The muscles of choice are biceps and vastus lateralis. The gastrocnemius muscle should be avoided since its tendon insertion extends throughout the muscle, and inadvertent sampling of a myotin tendinous junction may cause difficulty with interpretation. Typical myopathic abnormalities on biopsy include central nuclei, small and large hypertrophic round fibers, split fibers, degenerating and regenerating fibers, and increased connective tissue and fat. Inflammatory myopathies have mononuclear inflammatory cells in the endomysial and perimysial connective tissue between the fibers and occasionally around the blood vessels. In addition, dermatomyositis may have perifascicular atrophy. Inflammatory cell involvement of non-necrotic fibers is not prominent, and there might be deposition of C5b, C5-9 membrane attack complex on or around the small blood vessels. In polymyositis, there will be a variability in fiber size, scattered and necrotic and regenerating fibers with endomysial inflammation with invasion of non-necrotic muscle fibers. In IBM, we can see endomysial inflammation with invasion of non-necrotic muscle fibers, small group of atrophic fibers, eosinophilic cytoplasmic inclusions, and muscle fibers with one or more rimmed vacuoles with granular material can be seen. There is, the pathogenesis is believed to be via an amyloid pathogenesis. There is a deposition of amyloid on congruent staining. It may be TDP43 positive, and it may also be ubiquitin positive. The classical name of inclusion body myositis is because of the electron microscopy findings of 15 nanometer to 21 nanometer cytoplasmic and intranuclear inclusions of tubular filaments. This is an example of ragged red fibers, that is subsarcolemmal accumulation of abnormal mitochondria. This is best seen with modified Gomori trichrome stain. This is example of Nemeline myopathy, type 1 fiber predominance and atrophy is seen. There is marked disproportion in fiber size with uniformly small type 1 fibers and normal to large type 2 fibers. We can see Nemeline bodies that are sarcoplasmic rods, short, granular appearing, subsarcolemmal location, and perinuclear localization. These are composed of alpha-actinin, actin, and other Z-disc proteins. Centronuclear myopathy or myotubular myopathy is called centronuclear because of the predominance of small type 1 fibers with central nuclei. The type 1 fiber predominance is often small and atrophied. There is central pallor noted on ATPase staining, and radial distribution of sarcoplasmic strand is apparent on NADH reaction. Central core disease has type 1 fiber predominance. The central core is a single well-circumscribed region which selectively involves type 1 fibers. This area is deficient in mitochondria and sarcoplasmic reticulum as well as oxidative enzymes. Best detected on sections with oxidative enzyme immunohistochemistry. Nowadays, more and more molecular genetic studies are being done. Multiplex ligation dependent probe analysis, that is MLPA assay for DMD and BMD. There is optical scanning of the genome for DUX4 derepression in FSSD, myotonic dystrophy type 1 and type 2, OPMD, that is mitochondrial DNA sequencing, LGMD 1B, 2A, 2C, 2F, and 2L can also be diagnosed by molecular genetic studies. And mutations in FKRP, FCMD, MEB, and PMT1 can be suggestive of congenital muscular dystrophy. MORPH and MELAS can be also be picked up on mitochondrial DNA sequencing. Thank you, sir.
Yeah, Doctor
I think it was
Rastik, there was one
too extensive.
pattern. I have seen one article for
Yes,
neuropathy.
sir.
That
Yes,
can
sir.
you open just one?
I'll share. Yes.
So common stains and all you should know. In exam, they might ask
Yes, sir.
like oil red O for lipid, past tense for glycogen storage, amyloid with